Okay, guys, I think all of you are here almost, and all of you watching my screen, except maybe one, who is the one that who needs the link before we will start. Alright, I will text it to you in all cases, just in case. Just in case the one that who does not have or who didn't have my screen yet. Okay, so basically rheumatology, is the backbone of outpatient, chapter, because most of the topics are, I mean most of the topics or diseases are outpatient treatment. So there is no such big emergency here, except maybe septic arthritis. Yeah, guys, please make sure noise. So we'll start, we'll start with SLE and these, and we'll start with SLE, I mean we'll start with connective tissue disease first, then we will walk to the joint, and then finally to the muscles. I mean we'll cover three major topics in rheumatology. So, and also we'll cover it by differential diagnosis or whole disease. So let's see if we can make this simple chart. SLE, guys, how many types? First, you have three types, you have four types, depends on ANA serology. If ANA positive or negative. So I don't know, let's make it like this way. If ANA negative, here you have a category called ANA negative lupus. So basically this category is ANA negative lupus. Now, if ANA positive, and this is the big category, here you will divide it further according to whether systemic involvement or not. So then you will go, if you will see patient like SLE, you think it's SLE and ANA positive, which is usually the most common, you will go next with systemic. You will go next to systemic features, whether it's present or not. If systemic features negative, that means not present, your answer will be discoid lupus. And this is the only type of lupus arthritis with no systemic features, but basically ANA positive, guys. So if he will give you discoid-like reaction, he will tell you this, guys, he will not hide this. I don't think he will describe it, but he will tell you this discoid-like reaction, and that's it. Normal renal, normal CNS, everything normal, and usually the treatment just hydroxychloroquine for those. I will talk about this later. So negative, you have discoid lupus, ANA positive. Now positive, which is basically, this is our big category, you will divide it into also another two types. Once you will see systemic features positive, go with renal and CNS features. If you will see renal CNS positive, here you are talking about spontaneous lupus, which is basically the regular one. If you will see renal and CNS negative, you are talking about drug-induced lupus. Alright, guys, so far? So you have, I think this is important just to know the types in general. What is discoid lupus? What is drug-induced? What is spontaneous? Hey, make sure the papers, please. What's spontaneous, which is basically the most common types. Hey guys, please make it muted, please. One is this, yeah, please, the papers just beside my ears. Anyway, so ANA lupus, so for each one of them there is something specific. For discoid lupus, guys, he will not ask you more, just, either diagnosis or the treatment we'll talk about. I mean, you don't need to know more than this chart in discoid lupus. For NA lupus, those patient serology and those patient clinical features, basically you will see raynaud's here positive, and those patients that have different serology, which is anti-SSA positive, which is anti-Rho. So here anti-Rho positive, which is basically anti-SSA. Hey guys, please, either someone walking or someone hammering. I mean, not on you, but on your side. So please make it mute. All of you make it mute now, because in the beginning I will not ask in the first 15 minutes. So all of you muted, please. Thank you. So you have raynaud's, you have anti-RO, which is SSA positive, and those patients, yeah, thank you. Oh, now it's better. And those patients, why I mention it here, because there is a disease which is very high yield, basically. It's neonatal lupus is here. So neonatal lupus, usually the patient, the mother have ANA positive, negative, and maybe the mother just have anti-Rho, SSA positive, which could be part of Sjogren, basically. This could be part of Sjogren syndrome, which is the secondary Sjogren. And we'll talk about Sjogren two types, but this is the secondary type of Sjogren's, which is anti-Rho positive or SSA positive. In this case, you have a question which is really common. In this case, the patient or the neonate, if this is woman, so there is risk for neonatal lupus. And you know the key features of neonatal lupus basically is congenital heart block. Alright, so that's it. We're done with that. There is no other issues about negative ANA. That's it. Discoid, we're done. Drug-induced and spontaneous. I prefer to go to serology first, which is also it's also easy. Now, both of them, the initial test, guys, I don't think you need to know what is the initial test for lupus, because it's very easy, just ANA. I already made it here. Okay, so this is, I mean, this is makes sense. Initial. You will not do chest X-ray, you will not do ESR, you will not do CRP, CBC. These are already done. Best initial to diagnose or screen. This is SLE. I mean ANA. Now, drug-induced lupus and spontaneous serology, I need to confirm it. So in drug-induced lupus, I think most of you have this antihistone antibody here positive. While in spontaneous lupus, you have two. The most specific is anti-Smith. Anti-Smith is still the most specific one. The second one, which is also specific, is anti-double-stranded DNA. Sorry, this is D. Why I make anti-Smith is the first, because guys, there is no other disease that anti-Smith positive except than SLE. All right, no other disease that anti-Smith positive except, so it's really specific. But what is the problem here? Usually it's not sensitive enough. I mean, you know how many patients that have ANA anti-smooth muscle positive regarding sensitivity? Just 40%. So 40%, you don't need to know the percent, but why I mention it here, because this is less sensitive than this one. Maybe this also, it's hard, don't know it. Okay, forget it. The most common is, the most specific is anti-Smith. Second one will be anti-DNA. Why? Anti-DNA usually indicate either SLE, which usually the case, or could be also present in Sjogren. That's why that's why I put it in the second one. All right, this is very high yield, and I think antihistone is easy, guys. Now, so far for drug-induced lupus, you can read it. ANA positive, systemic features, but what are the features? Positive renal and CNS? No, because he's negative. I told you negative features. So basically you can say no CNS features, no renal features. The skin, even the skin features, and you know these, the typical butterfly rash, And what else? Alopecia and ulcers. These typical features are not so typical as in a drug-induced, but still you can say rash. You can say the rash, but it's usually not typical like spontaneous. I mean, spontaneous, you will see the butterfly rash, alopecia, and all of these stuff. Here, you will see it, but not so typical like spontaneous. So this is how you make drug-induced lupus. And finally, also, I think most of you know this drug, which is hydralazine, procainamide, INH, methyl-dopa, quinidine. I will just mention one. INH, and I'll mention these because it's, I think this is just classical. INH, hydralazine, procainamide, quinidine, whatever. Now, for spontaneous lupus, let's go to the criteria. How you will know that patient have lupus? It's a criteria, guys, and I will make it here. I will start with number 1. And then all of these represent the whole spontaneous lupus. I'm talking about now this one, which is the big time. First, guys, I think you need to know there is rash. And the rash is different features, you know, butterfly rash and whatever. You have a lot of features, but butterfly is important. A discoid rash here is also important in spontaneous. Maybe you will see discoid, right? Discoid in spontaneous too. What else? Alopecia. So all of these just rash problems. Maybe photosensitivity, usually almost the same as rash. So this is the first criteria, guys. Each one of these represent 1 point. Guys, the criteria, the idea of the criteria, you will calculate how much clinical features you will get, and then if you will get 4 out of 11, in this case, you can do ANA for the patient. This is what I mean by criteria. So you will calculate, this is butterfly positive, so this you will give this 1, this is 2, this is 3, this is 4. If you will get 4 out of 11, so that's mean do ANA. So, but I will consider this 1 because I'm talking about just on the rash as a point. But all of these guys, as I told you, is sub-point. Now, the second important thing, arthritis. Talk about arthritis just a few minutes. Third one, I think, is also important, pericarditis or pleurisy or serositis. Means pleurisy, means pleural effusion. And then you will have renal. I need to go further. You have what else? You have hematological features like anemia, I think, and thrombocytopenia. And a lot of thrombocytopenic patients, which is basically idiopathic thrombocytopenic purpura or just accidental finding, they discover later on that patient have SLE. So this is 4, 5, 6. What else? 6 that we have. We talk CNS like seizure and psychosis. 7. What else in 7? I think that's it. Yeah, I think that's it. Why? Because they mentioned 7 and 5 as what? As serology. Sorry, 7 and 6 as serology. So you can say 6 CNS and 7 serology. And serology you will give point to the ANA. So ANA represent 1 point, and the specific, you know, these specific represent another point. So basically, now if you will calculate it, you will see really there are a lot. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. It's around, I think it's around 11 or 12. All right. So this is the features. And he may give you 2 or 3 of them, and then he will ask you whether the patient needs ANA or not. If you will calculate more than 4, go with ANA. If less than 4, you will not go with ANA. And I think, you know, guys, all of these 3, the first 3, you can call it, it's a kind of early. So you can divide it into early features. Everything above is early, and anything below is late features. Sure, renal and CNS big time late. Now the questions for arthritis, the patient will come with joint pain, and this joint pain is metacarpophalangeal joint and the proximal interphalangeal joint. So the metacarpophalangeal joint, proximal interphalangeal joint. Now guys, I think the time for some questions. Say Mayun here. Let me ask one by one. But metacarpophalangeal joint and proximal interphalangeal joint, in case of SLE, can you tell me what is the X-ray finding of of metacarpopharyngeal joint, proximal interpharyngeal joint in case of SLE? You hear, Seima? You hear me?
Yes, I'm here. But I don't know the answer of the question you're asking, please. Sorry.
Okay, now and I'll ask another question. Do you think the joints are severely affected or not?
Yeah, I guess so.
It's non-erosive. This is the it's not effective, guys, severely. It's non-erosive. And this is really big time, really very high yield. Once you will hear non-erosive arthritis, that represent SLE. Okay, guys, which is metacarpopharyngeal joint, proximal interpharyngeal joint. Now, I need another differential diagnosis of non-erosive metacarpopharyngeal and proximal interpharyngeal joint. Another differential diagnosis will be viral arthritis, guys. And when I talk about viral, I mean I'm talking about parvo here. Okay, if you will see proximal interpharyngeal and metacarpopharyngeal joint, but it's erosive, which is I think big time, means which is differential diagnosis. This is differential, guys. I mean it's not SLE now. Question is differential. Yes, Ali. Metacarpopharyngeal, proximal interpharyngeal, but it's erosive. Can you tell me a disease here?
Maybe rheumatoid?
Very good, rheumatoid arthritis. So this is your differential diagnosis, guys, because metacarpopharyngeal, proximal interpharyngeal, you only have 3 diseases. The first one is non-erosive, which is basically our topic SLE. The second one, also non-erosive, which is viral arthritis, which is very common. I will talk about that, usually less than 6 weeks. And the last one, erosive one, the difficult one, is the, it's just the rheumatoid arthritis. So this is...
Sir, I want to ask, what is the difference between the viral one and the SLE one?
Sorry, what is the difference between what you said again? Can you repeat it?
The viral and SLE one, both are non-erosive.
Oh yeah, there is no difference. I mean, yeah, both of them, they are non-erosive, but you have to get more clinical features. For example, how you'll make a case like viral? How you'll make a case like viral, guys? I mean, it's really interesting. I mean, this question is interesting, but it's usually no different. In a kind
because the questions they generally just state this history of a school teacher or something
right.
like that, but otherwise how do you
differentiate? Otherwise you cannot make it. So usually non-erosive joint, usually less than 6 weeks, and a school teacher. Why school teacher? Because maybe the children, students, one of the people or children have parvovirus, and then when the adult gets parvovirus, usually parvovirus in the adult present as just joint, not slap cheek, which is usually the classical for parvo in children. So, but for viral, you get less than 6 weeks, and you get school teachers. This is basically here I'm talking about viral, which is parvo. Now for SLE, sure I'm not talking about less than 6 weeks. So here maybe you can say more than 6 weeks, and then guys you can add others criteria, right? So that's how you make it. He will give you other criteria for non-erosive arthritis to say it is SLE. Alright, this is just here, not. Question? Any question, guys? We can move? Alright, so I think that's most of the thing about SLE. Renal. The most common renal manifestation, there are 4 stages, and I don't think stages is important. It's not important for us. But the most important one is diffuse proliferative glomerulonephritis. This is the most important stage. Diffuse proliferative, so most common. Diffuse proliferative glomerulonephritis. And here, basically, the immunological mediated, this is immune complex mediated disease, right, guys? Make sure you all know these, although it's patho, but this is also important. Sometimes they ask because I think it's just basic. Immune complex, all SLE is type 3 hypersensitivity reaction, which is immune complex disease. And just in case, because you were talking about this immune complex, you know you have differential diagnosis, which is basically for foreground arthritis. So maybe he will give you this immune complex means SLE. So differential diagnosis, this is another note about groin arthritis, pathological wise. Maybe he will give you another disease, IgE mediated. This is differential. Or maybe he will give you cytotoxic antibody mediated. This is another differential. Or maybe non-immune damage. They like this. As I told you, they will not give you usually the answer right away. This is SLE or whatever. So IgE mediated, this is not non-glomerular disease. This is usually IAN, means acute interstitial nephritis. Cytotoxic antibodies, I think you find with this, means Good-Pasteur syndrome. And non-immune damage to the kidney means by toxin or by ischemic or usually by hypertension. These are the non-immune damage. I mean, these are the terms for not, yeah, I think this is not so accurate, not just for glomerulonephritis. These are the terms for a mechanism of kidney damage. Right? Maybe he will give you something in tubules. That means he's talking about ATN, whether ischemic or toxic. Again, this topic here, which is the small one, this differential diagnosis. That's why I make it note. And this, you have another note here. I know the slide now is overcrowded, but I would like to make it just one page at least. So you have another note, which is non-erosive joint differential diagnosis. And you have differential diagnosis of kidney damage in general. They are a lot, but because no space. Now we'll go back to our biggest slide, A&E first positive, go with whether systemic features and see what are these systemic features. Guys, this is maybe a kind of confused, not so accurate, but that means no renal, no CNS here. So here basically I'm talking about the drug-induced, and I think antihistone is very high yield, and most of you know. Spontaneous, try to calculate how much criteria you will have, count how much criteria, 4 out of 10, that means indicate for ANA. The most specific, which is anti-Smith, and the second one you will go with anti-DNA. Both of them specific enough. All right? Any question? There is no test without SLE, by the way. He has to ask about SLE. And we didn't talk about treatment yet, which is much easier.
Riyadh, I'm sorry, I wasn't here. What is this with the less than 6 weeks and greater than 6 weeks?
Okay, give me a few minutes. We'll talk about that in major details in rheumatoid arthritis.
Okay.
Okay, so it's okay. It's not a big deal here. Now, as we made the SLE, I will make this simple diagram for the treatment, which is basically early, right, and late. And early means usually skin and neurological features, and late usually means renal. So early, guys, which is basically skin, and late renal CNS. Now the drug of choice for early, Valley, do you know the drug of choice for early SLE?
Hydroxychloroquine.
Right, but you know also a patient have, I didn't mention it, a patient have also arthritis. So usually you will start always with non-steroidal, right? Maybe you will see, maybe you will go with avoid sun exposure, and then non-steroidal anti-inflammatory drugs, and then you will go with hydroxyurea. But she's right, hydroxyurea is the drug of choice. Now, Valley, do you know before hydroxychloroquine, what I have to do for the patient? And what I have to do for
yes, you need to check, I think, for retinal toxicity because hydroxychloroquine causes retinal toxicity.
So very good. So check the eye. And can you tell me the drug of choice for late? And when I'm talking about late, I'm talking about renal I mean hematuria patient and maybe proteinuria positive, negative. What is the drug of choice?
The drug would be steroids, I think.
Steroid for a flare. So you are right. I can put here steroid for the flare means acute problem. I mean the patient came with acute lupus. All of these features plus high ESR plus fever. So this is acute or flare. Flare, guys, you will see the patient is really sick. Means all of these features, which is basically you can say criteria for the flare, plus fever, criteria, plus fever, plus really very severe high increase as ESR. This is treatment. Those they treated by steroid, and the steroid they will give them also pulse steroid therapy, which is very high dose of steroid, like MS patient. Now, how about the long term? How you will treat renal? Not long term, basic. How you treat renal? Valley, still questions for you. How you will treat renal patient?
I'm trying to think what I treat renal with.
Only one.
I'm not so sure.
Only one drug, which is not so hard. Cyclophosphamide.
Oh, okay.
And they will give those cyclophosphamide is a kind of, guys, monthly for 6 months. So, Ali, because they will give it monthly for 6 months, there is some complication important you need to avoid it. Do you know what is this complication and how you avoid it?
Is it the hemorrhagic cystitis?
Right, and how you'll avoid it?
You give Mesna?
Right, that's it. So guys, make sure about this hemorrhagic cystitis equations and Mesna as differential, as prevention. All right. Do you remember how you will prevent? This is just differential diagnosis about prevention. Do you know how to prevent? I will make this small note. How you'll prevent urate how you will prevent two disease, contrast-induced nephropathy. So you'll tell me one answer. Maybe Michael will tell me one answer. And how you will prevent urate nephropathy. Because these are also prevention questions. What you will give, Michael, what you will give the patient to prevent contrast nephropathy, Michael?
You mean contrast nephropathy?
Yeah, how you will prevent it?
I think you will give, you will give...
Yeah, you're right, almost. What is it?
You give normal saline or you...
Very good, normal saline, which is IV fluid, plus negative N-acetylcysteine. Alright guys, that's why I make it here. How you prevent urate nephropathy, Michael?
Urate nephropathy?
You remember?
Is it you're going to give allopurinol?
Right.
Is that?
So you'll give NaHCO3, alkalinize the urine, and you'll give allopurinol. That's very good. All right. These are pre-treatment stuff. So for Mesna, hemorrhagic cystitis, what you usually give with methotrexate? Although I will talk about this methotrexate rheumatology, but what do you usually guys give with methotrexate? Folate.
Folic acid?
Yeah, folic acid or folic acid. Usually methotrexate given weekly. Just before methotrexate, you will give folic acid. I think I'm done with the SLE. That's too much details. All of these just important. Sure, hydroxychloroquine is important. No way. I mean, this is for early. You need to know the drug. Just 3 drugs: hydroxychloroquine for early, steroid for flare usually, cyclophosphamide for renal problem. Make sure about hemorrhagic cystitis to add Mesna. That's it. Any question, guys, for SLE before we'll move to the second topic?
Please, I can't see the screen. What is happening? I don't know. Should I just...
What's happening? I don't know either. Okay, sign out and sign in again. Just now you didn't see it, or from the beginning? Hey, Michael, from the beginning of lecture or just now?
From the beginning.
Oh, really? Why you didn't tell me then? I ask you guys this question. So how you are following me then? Without watching the screen?
I'm hearing. I can hear, but I can't see.
But
that's the problem.
because I know one is not here, that's why I ask. All right, here is the link again. Hey guys, you cannot just hear. I mean, you have to tell me. Even, I mean, it's okay, even if you will, disturb the class for a few seconds, because this is, for all of you. So here is not, if you have a problem with the computer, that's different. So, Michael, I texted you the link now. Hopefully it will work for you.
So, Riyadh, because of death in SLE, it will be renal or cardiac?
Oh, by the way, the cause of death in SLE will be renal or cardiac or infection. This is interesting. I don't think it's cardiac here. I think the cause of death is renal. Or wait a second, really?
I think it's renal.
Renal, I think it's renal. I'm not sure.
Yeah, it is renal, I guess. I read it somewhere.
Yeah, I think it's renal.
Young is infection, in elderly is atherosclerosis.
Oh, okay. Yeah, this is more interesting. I think this is more accurate. So here you can say death. The cause of death in young will be infection. And the cause of death in elderly means atherosclerosis. And I don't know. I think this atherosclerosis just the common, which is, so in this case, Radwan, if he's talking about atherosclerosis, so the cause of death will be cardiac.
Yeah.
Yeah, guys, make sure you will, one of you, or after the lecture, or maybe me, make sure this is right.